early 1800s, cholera was a disease that was entering into Great Britain, especially in England, causing widespread epidemics with very high mortality. In the 1850s, while they didn't know the cause of cholera, an outbreak occurred in an area in London called the Golden Square, where there were hundreds of patients and people within just a few days dying of cholera, suddenly, unpredictably. Dr. John Snow, who was an anesthesiologist by trade, also had the avocation or the hobby of investigating and trying to understand causes of infection and infectious disease. He did something that some had done before, but not nearly as extensively and in such detail. He went door to door, or found out from other sources, who and where people had lived and who they were when they died of cholera in the Golden Square in London. That was the area that was suddenly affected and had hundreds of people dying of cholera within a brief period of time. What he determined when he plotted out or had a graphic representation with this map of the causes and locations of cholera, that it was suspected that there was something in the water in the Broad Street pump that was the source of cholera. They weren't sure what it was. In fact, when they looked down below, they could see that sewage was leaking into the drinking water, and realized at that time people did not have indoor plumbing in terms of faucets where they could simply turn on a knob and get faucet in their home. They'd have to go to a municipal pump and transport the water from the pump to their home for drinking, bathing, eating, anything that they needed. Dr. Snow, realizing that the Broad Street pump appeared to be at the center of this particular outbreak, recommended that the handle be taken off the pump. And sure enough, the number of cases of cholera decreased roughly 90% from what had occurred before the handle was taken off the pump. He's recognized as the father of modern epidemiology. There are other ancestors or ancient resources who also had some of the same kinds of ideas, but Dr. Snow really is the first modern physician and epidemiologist to give us the tools that we still use today to track disease. Portals of entry are where microorganisms that can cause disease get into our body. Portals of exit are places where they come out. Oftentimes, we have areas on our body that do both. Our nose, mouth, eyes, ears. Those are just a few examples of parts of our bodies that can be both portals of entry and exit. Here you see the illustration of a nice healthy sneeze and the fine aerosol mist that comes out of the upper respiratory tract when someone sneezes. And you can also have a fairly good idea of the extent or the distance the spray will go if you don't somehow contain it. Oftentimes, political turmoil, warfare, other types of changes that occur in the world can change or tilt or shift the number of cases of particular disease and make it difficult to control diseases. In the early 1940s, especially with the advent and use of antibiotics, we found that many diseases, especially infectious diseases, were on the decline. Then with the advent of the Korean War, the Vietnam War, and refugees migrating or immigrating to the United States, we often would see spikes or epidemics of disease occasionally occurring when veterans would come back to the United States ill, or immigrants would enter into the United States, essentially bringing with them some possible disease organisms. So oftentimes we have a fairly good handle or control of the occurrence of diseases that affect public health, but events do happen that could cause a shift. We always have to be on the alert to make certain that we can control and contain any events that do begin to occur. The World Health Organization, or WHO, is the world's premier public health agency. Member nations participate and share information. Not every country in the world is a member of WHO, but most are. And it does give us all a chance, regardless of our national heritage, to work together for the common good, to make certain all citizens of the earth are healthy and productive. WHO has determined that the majority of deaths from infectious diseases could be prevented. Anytime you have a population of individuals who are ill, their productivity and the hazards that can essentially be spread to other neighboring nations is a high priority and a problem. Deaths that are avoidable, deaths that are unavoidable, what can we do to balance out the kind of mortality that we do see in some countries? Childhood vaccinations, the use of bed nets to prevent malaria, directly observed treatments for conditions like tuberculosis, integrated management of childhood illness to make sure that children aren't dying from diarrheal or contagious diseases like measles, the use of antibodies with the appropriate dosage to control certain diseases, preventing strategies, promoting appropriate education for citizens to make certain that they're using all types of safety precautions so they can be safe and healthy, productive citizens in every country. Hospital-acquired illness. What are the most likely pathogens to be recovered if you happen to develop an infection while you were in a medical center or healthcare facility? Well, top on the list would be Escherichia coli and Staphylococcus aureus. We'll find that the leading causes of infection in terms of pathogens will correlate with the leading body sites, or the most common body sites that we'll see in another graphic representation. So E. coli and Staph aureus, number 1 and 2. Occasionally they can flip-flop back and forth, and Staphylococcus aureus could be number 1. It depends on what's the most common type of infection, what body site is infected. Farther down the list, we have Streptococcus and Pseudomonas. Other members of Enterobacteriaceae, along with the Escherichia coli, would be Klebsiella and Enterobacter. Candida does cause a few cases of hospital-acquired infections, which is Candida is a yeast. And then Staphylococcus epidermidis, Bacteroides serratia, and then several other types of pathogens, which you might identify as sort of miscellaneous, rare but do occur occasionally. Please make certain that you do know essentially the top 5, from E. coli to Klebsiella. Here's an illustration of how bacteria can wind up in a patient who's in a hospital. It can come from other patients, from the outside world if a window is open, contaminated equipment, visitors that happen to bring bacteria with them, even insects, air coming from elevator shafts or other kinds of air handlers. It's just amazing at how many different ways that we have to introduce unwanted microorganisms into a facility like a hospital. And if that weren't enough, sometimes the patients bring, of course, their own microorganisms with them. The patients come in, the bacteria stay when the patients leave. There's an old saying, if you weren't sick when you got into the hospital or went into the hospital, you would be when you left. And unfortunately, that's more true today than it was 30 years ago. Tracking the number of cases of hospital-acquired or nosocomial infection is somewhat variable. I don't know if there are any federal regulations that require that type of bookkeeping. Usually in-house or in a particular facility, there are infection control officers or individuals who are responsible to make certain that those types of hospital-acquired infections don't become a serious problem or even occur at all. But it's been estimated that hundreds of thousands of individuals, at least in the past, have developed hospital-acquired infections that could have been prevented by simply being aware of the location and the types of modes of transmission of bacteria that can affect a patient who's in the hospital or a medical center, nursing home, or hospice. This is an illustration of the type of equipment that could be used on a patient and where we might have essentially breaks in the system or leaks in the system that would allow bacteria to enter. And some of the bacteria that could enter in this type of an example would be possibly even an environmental microorganism, not necessarily a pathogen. Unfortunately, many of the environmental organisms are even more drug resistant than the typical types of microbes that we find in and on the human body that usually cause disease. So leaks in tubing, stoppers, breaks in the system, compressed air that isn't properly filtered. We have injectables or IV solutions that aren't properly filtered, contaminated dialysis pumps, contaminated tubing, improper portals where we have essentially anything that's been inserted into an artery or vein leaks or is contaminated at the site of the catheter. It's just amazing the number of places that we can have inappropriate microorganisms introduced into a person's body. And you can't surpass or find an even better mechanism of transferring microbes into a person than a needle into a blood vessel. Here's a pie chart illustrating the body sites that are most often the location of nosocomial infections. Notice that urinary tract and surgical wounds are at the top of the list, along with respiratory tract. If you overlay this chart with the most common types of microbes, we'll see that it makes more sense, so you can understand why Escherichia coli is number one on the list if UTIs are number one on the list. Now, these charts are changing rapidly because of the change in reimbursement that's occurred over the past many years by third-party payers, in particular Medicare. Medicare and Medicaid will no longer reimburse for nosocomial UTIs or urinary tract infections, and we're finding a dramatic change. In fact, it's not going to take too long before it's going to be standard practice, and we're not going to even remember the days when patients would go into a hospital and frequently contract urinary tract infections, because catheters are no longer left indwelling for any length of time that's really considered inappropriate or not beneficial to the patient. So now we find that catheterization of the urinary tract only occurs when necessary, and then catheters are quickly removed. So we'll see a dramatic shift as more and more data is collected, and possibly surgical wounds and respiratory tract will be number 1 and 2, and UTIs will be way down the list. But that's the kind of graphic representation that epidemiologists will use to evaluate and compare either hospital-acquired infections, public infections, or epidemics that are occurring in a nation, a city, a state. There are all types of ways we can take the data that's accumulated and illustrate in a graphic representation or a picture or some kind of other way of conveying that information to the general public or to scientists to get an idea of causes, relationships, and ways that we can either stop the mode of transmission, figure out ways of treatment. All types of analyses can be done once we have the data and we start to evaluate it and analyze it. Here's a photo of a containment unit. Should someone become sick or infected with a highly lethal, highly contagious pathogen, one that we could not risk escaping to the rest of the general public, the person might be confined to this type of self-contained stretcher. There's no way that the microbe that's causing the infection in this person to escape from this single contained unit. And in fact, these types of patients would be put in isolation. So this is essentially like an isolation stretcher. And these patients would be put in isolation rooms where no direct contact with the patient is possible. We cannot allow the pathogen to escape because, again, of its high lethality and contagion. With these types of pathogens, there are no treatments, there are no vaccines. We're simply trying to give supportive therapy as much as possible to the patient, and it's up to the patient's own immune system, primarily, to help the patient recover, if at all possible, when this type of infection occurs.